All right, we're going to do something a little different today. We're going to walk through a consultant-level surgical exam, the viva. This is that high-pressure oral exam where everything you've ever learned gets put on the line. So let's step into the exam room together.
And I don't want you to just watch. No. For the next few minutes, you are the candidate. That's right, you're in the hot seat. Imagine it. You're a senior surgical resident. Your entire certification is on the line. The examiners are staring you down, and the clock is ticking.
Okay, so I'm going to play both roles here. The examiner asking the tough questions and the candidate trying to answer them. We'll tackle a classic breast cancer case. I want you to follow along, think about what your next step would be, and see how it lines up. Ready? And just to make this feel as real as possible, this whole scenario is based on a mock exam for the Saudi Commission for Health Specialties. So yeah, this is the real deal. This is the kind of high-stakes situation that surgeons have to face to get certified.
Okay, the door closes, you take a seat. The lead examiner makes eye contact, clears his throat, and starts. I'm now playing the examiner.
A 55-year-old woman has presented to your clinic with an abnormal screening mammogram. A cluster of 5 microcalcifications within a 5 mm mass were seen in the upper outer quadrant of her right breast.
Doctor, how would you approach this patient?
Okay, switching hats. Now, I'm the candidate. The most important thing here is to be systematic. You absolutely cannot jump to conclusions. You start with the basics, the fundamentals, a really thorough history and a complete physical exam. It's like building your case one brick at a time. Well, first, I'd start with a comprehensive history. I'd structure it to cover a few key areas. I'd want a full review of symptoms, especially asking about breast masses or discharge, but also things like bone pain, to check for potential metastatic disease. Then, I'd get a detailed gynecological history to figure out her hormonal risk factors. Of course, her past medical history is crucial. Any previous breast biopsies? And finally, a really detailed family history is an absolute must to see if there's a genetic red flag like BRCA mutations.
Okay, she tells you her mammogram from last year was completely normal. What's your next move? Right, after the history, I'd move on to a systematic physical examination. I'd start with her general appearance and vitals, then a complete breast exam, looking for any asymmetry, skin changes like dimpling, and carefully palpating all 4 quadrants of both breasts and into the armpit. And last, I check the axillary and supraclavicular areas for any swollen lymph nodes. And the examiner tells me, your examination is completely normal. No masses are felt, and there is no lymphadenopathy.
So the history is non-contributory, and the physical exam is normal. How are you going to manage this patient?
Okay, so since the physical exam didn't show anything, my next step has to be investigating that mammogram finding. I'd order a targeted ultrasound. And in this case, it shows a 5 mm hyperechoic mass. That just means it looks bright on the ultrasound. And it has an irregular border. That's a suspicious finding. So the next definitive step is an ultrasound-guided core needle biopsy. We need tissue. The pathology comes back as ductal carcinoma in situ, or DCIS, which is basically a non-invasive stage 0 breast cancer.
All right, doctor. The diagnosis is DCIS. What's your plan now?
My plan is surgery. We need to excise this lesion. And because it's non-palpable, meaning I can't feel it, I'll need to do a wire-localized partial mastectomy, which you probably know as a lumpectomy. Essentially, a radiologist uses imaging to place a thin wire right into the target area just before surgery. That wire acts as a roadmap, making sure I can remove the entire lesion accurately.
So, the first surgery is done. Everything seems to have gone to plan. But in any complex case like this, you have to be ready for a curveball. And the final pathology report, the one from the tissue we just removed, that's where the real story often comes out. And in this exam, things are about to get a whole lot more complicated.
The final pathology report has arrived, and it shows 3 critical findings. First, there is a 12 mm invasive ductal carcinoma. This is a major upgrade from the pre-op diagnosis of DCIS. Second, the margins for the DCIS component are positive, which means we didn't get it all. And third, the tumor is triple negative. That means it doesn't have the common hormone receptors that we can target with therapy, and that generally points to a more aggressive type of cancer. Wow, this is a complete game changer. We've got an unexpected invasive cancer, positive margins for the DCIS, and an aggressive tumor type. This is that classic moment in an exam where you, as the candidate, have to pivot, and fast. You have to come up with a totally new, more aggressive plan because what we did before just isn't enough anymore.
Doctor, given these new and significant findings, what will you do next?
Okay, given this new information, my approach now involves 3 absolutely critical steps. First, and this is the most important thing, I'm going to present this case at our multidisciplinary tumor board. You need input from oncology, radiology, pathology, everyone. Second, because we now know there's invasive cancer, we have to surgically stage the axilla. That's mandatory. We didn't need to for pure DCIS, but now we do. So I'll perform a sentinel lymph node biopsy. And third, those DCIS margins are positive, so we have to go back. A re-excision of the lumpectomy cavity is non-negotiable to make sure we get clear margins. You proceed with that plan, the pathology from the re-excision comes back, and you now have negative margins for the DCIS. The sentinel lymph node biopsy is also negative. 0 out of 2 nodes show any signs of metastasis.
So, the surgery is done, and it was successful. But the exam isn't over yet, not by a long shot. A great surgeon understands that the patient's journey doesn't end when they leave the operating room. Now we have to talk about what comes next, the adjuvant or postoperative care.
You've achieved clear margins, and you've staged the axilla. What next, doctor? The patient's long-term care plan is going to have a few key parts. First, she's going to need adjuvant radiation therapy to the whole breast to cut down the risk of local recurrence. Second, and this is crucial, because this is an invasive triple-negative cancer that's over a centimeter, she absolutely must be referred to medical oncology. They'll need to consider systemic chemotherapy to take care of any potential microscopic disease floating around. And finally, I'll set up a long-term surveillance plan. We'll see her for clinical exams every 3 months for the first couple of years, and she'll get an annual diagnostic mammogram. And that's it. The viva's over. We've gone from a subtle finding on a mammogram all the way through a really complex, multi-step treatment plan. And I think it just goes to show, in surgery, your first plan is really just a starting point. The real test is how you adapt when you get new, unexpected information. So I'll leave you with this question to chew on. What do you think was the single most critical decision point in this whole case? Was it the choice to biopsy? The decision to go back to the OR? Or was it that discussion at the tumor board? You know, there isn't one perfect answer, but thinking about why you'd choose one over the other, well, that's the very heart of surgical judgment.